Welcome to this ASN Kidney 360 podcast. I am Magdalena Madero, head of the nephrology department at the Instituto Nacional de Cardiología Ignacio Chávez, Mexico City. I'm joined by my colleague, Enzo Vazquez, third-year nephrology fellow at my institution. Today, we will discuss our article entitled Global Dialysis Perspective in Mexico, published in Kidney 360 this past June.
Please answer the following questions. First question. Please describe the barriers to renal replacement therapy in our country.
So the main barriers to renal replacement therapy in Mexico start with the lack of renal registry, followed by the lack of universal coverage. Access to renal replacement therapy is limited or non-existent for the uninsured population, which represents 49% of the country's population. Out of these, only 3% can afford private health insurance, leaving the rest without access to Social Security benefits or private health care services.
What are the dialysis options for uninsured patients in Mexico?
So the uninsured population can access health services through the Ministry of Health with a significant out-of-pocket cost to the people who use them. Significant differences are observed between the insured and non-insured Mexican population. Universal health care coverage for renal replacement therapy is not available for the Mexican population. In Mexico, the renal replacement therapy offered are peritoneal dialysis, hemodialysis, and kidney transplantation. Home hemodialysis programs are non-existent in our country. Unfortunately, because uninsured patients require out-of-pocket payment for the renal replacement therapy, a large majority die without access to care.
The proportion of dialysis patients in Mexico on PD is about 60%, one of the highest rates in the world. Please explain how this has been accomplished.
Sure. So Mexico has a PD-first approach, especially at the level of the insured patients. This has been a health public policy where patients do not get to choose the renal replacement therapy modality and are placed on peritoneal dialysis first. This has resulted in lower expenses to the healthcare system and similar outcomes compared to hemodialysis.
And only 8% of hemodialysis patients in Mexico have an arteriovenous fistula. What accounts for this low rate?
This low rate is due mostly to late referral. In Mexico, we lack enough nephrologists, and unfortunately, most patients start renal replacement therapy as an emergency versus planned procedure. This results in poor preparation for renal replacement therapy initiation, and therefore, the majority of the patients start hemodialysis with a central venous catheter as an access. After this, many hemodialysis units are actually not run by a nephrologist, but by a primary care physician, and therefore, follow-up for AV fistula creation is somehow limited. So in conclusion, CKD care in Mexico is suboptimal. Outcomes are far worse in the uninsured population. Urgent recognition of CKD by the authorities as a public health problem is warranted in order to optimize healthcare services and improve access to care in our population. Thank you for joining us for this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.